You're listening to the UBC Medicine Learning Network.
Welcome, you're listening to Metamorphosis, a podcast designed to help medical students navigate their medical careers. My name is Igor, and on today's episode, I'll be speaking with Dr. Janessa Laskin, a clinical associate professor of medicine in the Division of Medical Oncology at UBC. She's also the co-founder and clinical lead for BC Cancer's personalized OncoGenomics program. So thank you so much for joining us, Dr. Laskin.
My pleasure, Igor.
Okay, can you tell us a little bit about your practice and what you kind of do on a daily basis?
Sure. So as you said, I'm a medical oncologist. So that means that I think about chemotherapy and how chemotherapy may help the patients that I see, or in a lot of cases may not help, because with not choosing to use treatment is just as important, if not more so, than trying to pick the right treatment for people. I personally specialize primarily in lung cancer, so about 80% of my practice from a clinical perspective is lung cancer. And then I also see people with head and neck cancers. And I work here in BC Cancer at the Vancouver site, which is a teaching and research facility as well. So a big part of my job is seeing residents, medical students, and fellows. So they're integrated into my clinic, and I do often mentor students in research projects and so on. And then I also have the opportunity to do a variety of different research projects. So I am the principal investigator of a number of clinical trials, or else I enroll patients on clinical trials with my colleagues. So that's usually new treatments that are coming along for patients, which is a really exciting part of oncology. The field evolves very quickly, which is one of the things I love about it. And then I also, as you said, I'm the co-lead of the personalized oncogenomics program, which is a big genomics cancer research project that I'm also very excited about. I'm sure you're going to ask me other questions. So my day-to-day life is a blend of clinics. So I see patients in clinic, and then I do associated clinic work, phoning them, or the general paperwork that is associated with patients, meetings, and talking to people about their care and so on. And then also trying to fit in all the research aspects as well. So it's pretty busy, but it's definitely not boring. And that's my day-to-day life. And I try to get home at a reasonable hour.
That's always important.
Doesn't always work. Yes.
Well, that's fascinating. That sounds like you have a lot of roles to balance and juggle. Did you always know that you wanted to get involved in all of these things, medical oncology and research and teaching and everything?
No, I mean, I don't think I was the kind of person that had my life mapped out. Certainly in medical school, I was always somewhat jealous or envious of the people who knew from the very beginning they wanted to be a whatever, because I did not know that. But I also think that my lack of determination to do one particular thing allowed me to stay open to all sorts of different possibilities and things that I might be interested in that I didn't even know existed. I mean, I think that's one thing about medicine. You don't even know half the things that exist when you go into it. So no, I did not know where I would be. I don't even think 10 years ago I could tell you that I would for sure be here. Although I think, being in medicine, treating patients, being interested in research, that was something, of course, that has stayed with me from the beginning.
Mm-hmm. And I know you started your medical training here at UBC. So where did you kind of go from there? How did you end up where you are now?
Yeah, well, I grew up in BC, so when I graduated high school, I decided to go to Montreal, which I had never been to, just for an adventure. So I went to McGill, and at the time I did some science and a bit of genomics actually in my undergrad, where I got to, stick Drosophila on those waxy sticks and try to see their legs and figure out what kind they were. It was very basic genetics, which was really interesting, but I had no concept of how much I'd be doing now. But when I finished at McGill, I really did not have the grades or the drive to get into medicine. So I took a couple of years off and traveled and did other things, and then found that I kept coming back to this question about medicine. and being a lifelong career that would be interesting. And fortunately, I had a good family friend who was a bit of a mentor in that way, who encouraged me to go into medicine. And so I came back to BC to do that. So I went to medical school here, and then I stayed for internal medicine and actually medical oncology as well. And then I went to Nashville to go to Vanderbilt University, had a fantastic lung program at the time. And so I spent a year there doing a clinical fellowship in lung cancer with some really amazing people. And then I did not want to live and work in an American institution where I'd have to deal with insurance questions. And I guess I found my true socialist medicine roots at that point, and decided to come back to Vancouver. So I've been on staff here since 2003, which makes me very old. But it was a very good experience to live and work somewhere else, particularly the United States, because I think we have this idea that the Canadian medical system is in some way inferior, or that we don't have the kind of research. And that's not at all true. We have an amazing system. We have to be a lot more focused about our research and the questions that we ask. So we can't do everything, but I truly believe we have a very workable system that provides excellent patient care.
So was it just the sort of administrative, like insurance kind of thing? Is that what kind of drove you away from working in the States, or were there other differences that you noticed that you didn't?
How far and wide is this broadcast? No, I loved working there, and it was a wonderful opportunity to see. I think, a significant portion of my family is American, so still. I did feel like I was in a foreign country for sure in the southern U.S. I think it mostly highlighted the differences and allowed me to have some clarity in terms of where I thought I wanted to make a life and practice.
Well, it's nice to know that you took a bit of time off before you went into medicine. And I think that's something that a lot of students are worried about, taking breaks or time off. And I think it's very important to focus on our mental health, especially. So can you speak a little bit on that, why you decided to take a year off, or, how that impacted your ability to get into medicine? Do you think if that made a difference or?
Yeah. I mean, I think that there were a lot of people I did my undergraduate with who were, in all of the get into medical clubs and were determined, and that was their focus. And I just didn't feel like that was me. So I think I still did all my prerequisites, but I just didn't have that determination, I guess. And I feel like that allowed me to have more fun and do more interesting classes. I did a minor in history and philosophy of science, which was fantastic and really interesting. And I think broadened my experience in terms of being able to think about how medicine changes over time and how scientific questions evolve, and think about philosophy and psychology. None of those things were open to my friends who were just hardcore medicine keeners. And I mean, all power to them. A lot of them got into medicine and they've done great. That just didn't speak to me. So when I graduated, I really didn't have any idea what I was doing. I spent some time in Africa working in a small village. I traveled around. I actually had 2 years off. I then had to go and do some biochemistry, get my grades up so that I could actually get back to medicine and came at it with a bit more maturity and a determination that was really what I wanted to do. To be honest, I think it really helped me in terms of getting into medicine, because I was able to talk about something else. At the time, interviews, I think they're structured quite differently now, but at the time it was just a conversation with 3 different physicians. And because my experiences were so different than everybody else, living in a foreign country and doing other things, had my application stand out a little bit more. So actually, I think it was an advantage. I'm not sure it would be now because they're so structured, those interviews. But, if 100 people come along and they all have excellent grades, how are you going to remember and choose? So doing something different, I think, is actually quite helpful. And I still believe that's true. I still think the process is able to pick people out who have something slightly different to bring, and that's important. The truth is, when you're doing medicine, you're dealing with people all the time. You're dealing with people, and you're teaching people, you're talking to people. You can't just have one cookie cutter type of medical doctor. That doesn't work. You have to have a variety. So I guess I represented that variety at the time.
Mm-hmm. And during your time in medical school, were you involved in a lot of extracurricular things as well? And did some of them inform kind of your decision which residency you wanted to be?
Well, as I said, I was lucky. I had a close family friend who was an oncologist. And so from the very beginning, I was allowed to come and spend some time in an oncology clinic, which was a really wonderful experience. At the time, our program was very didactic in nature, so we didn't really even see patients until third or fourth year. So the ability to go and sit in a clinic and hear real conversations from the very beginning was a huge advantage to me, and it made me comfortable about oncology, which I think is a problem, because when you, unless you're in an oncology environment in a clinic with oncologists, you don't see the joy and the laughing and the long-term follow-up and the difficult conversations, but also just the day-to-day nature of what oncology is like. You don't really experience that with oncology patients in the hospital. So I think I got a really good, clear view of oncology from an early start. But I still wasn't sure that that's what I wanted to be. Extracurricular stuff, honestly, hardly remember. I think I did some things, but I think I mostly was just focused on trying to memorize the Krebs cycle and where the loops of Henle were and what they did and all that stuff.
Yeah. Well, can you tell us a little bit about what medical oncology entails and how is it different from other types of oncology?
Well, I guess there's medical oncology and radiation oncology, which is about using radiation. And then there's surgical oncology. I suppose there are surgeons in a variety of different surgical disciplines that focus more. And so, surgeons are surgeons, so they're thinking about things from a surgical perspective. Medical oncologists are internists, so we are comfortable with weighing pros and cons. There's not usually a hard and fast yes, no. It's a lot of weighing these individual balances for patients, which is not as much a surgical mindset, I think. Radiation is somewhere in between. Again, it's a surgical kind of intervention in the sense that it's a focused intervention. And usually the radiation oncologists are really fascinated by the machines and the physics and the math and the problem solving of all of the different body systems and how they can use their computers to best focus their magical beamy rays at the cancer. So they are all three specialties extremely important in cancer treatment, but quite different. One of the things I love about oncology is actually its multidisciplinary approach. So I'm the kind of person I like working in a group. I like working in a team. I like bouncing ideas off each other. I'm fine with being wrong occasionally about things. And so I like the input of other people, and that's critical when you're an oncologist. So at the heart of the three oncology specialties, they are quite different in terms of who you are as a decision maker and how you like to approach problems. I think radiation and surgery is much more yes, no, let's try an intervention or not. And medical oncology is much more individualized, I guess, in a decision-making framework.
Great. And so how long is the residency program for that? What's sort of the pathway to getting into medical oncology?
Well, first you have to do internal medicine. So usually that's a 3-year program at this point. And it's really, really important to be an internist in order to go ahead with oncology. Our patients are often very sick. Their complications are significant. We need to be very comfortable with all of their pre-cancerous comorbidities, so that we know what we can ignore and what we can't. Quite frankly, most of medical oncology is administering poisons. No matter how sophisticated we get with our targeted therapies, they still have a lot of side effects. And so it's really important to have a grounding in internal medicine. And after 3 years of internal medicine, I think, of course, you don't know everything, but you feel comfortable with diabetes management and high blood pressure and cardiac issues and all of the things that affect a patient with cancer. So that's a critical thing to do. And you also need, you have the opportunity in internal medicine to take a couple of months of each different specialty so that you can be comfortable with different antibiotics from infectious diseases and just all the different organs that are affected. And then it's 2 years of medical oncology focused training, which is usually a rotation around different body organs. I mean, right now, oncology is still divided by the cancer primary site. So it's, lung cancer starts in the lung, can spread all over the place, but it's lung cancer. And so we have residents rotate through the different organ systems, learning how cancer affects these systems and all the different treatment approaches. And, medical oncology is almost entirely outpatient based. So that's a big learning curve too, because a lot of what you learn in internal medicine residency is hospital-based practice. And you have to learn how to deal with phone calls, how to figure out who's sick and who isn't based on a phone call, and who you need to see, and how people handle medications at home. And so that's a big learning curve as well. And then a lot of us, if you want to do research, a lot of us do a year or two of a fellowship afterwards. So just to have the opportunity to dive deep into a particular organ system and really feel like you're an expert in that.
So would you say that it's a good specialty for somebody who enjoys that sort of wide scope of practice?
Yeah, I think the way I approached trying to figure out what I wanted to do is by the process of elimination. And I'm not sure that that's how everybody should do it by any means, but this is what worked for me. I clearly was not a surgeon from the very beginning. I greatly admire surgeons, but I don't have that kind of immediate confidence about cutting something out or not. I like to sort of mull over a problem and look at it from lots of different directions. And you do not want a surgeon that's doing that. Maybe I should take out your appendix. Ooh, maybe I shouldn't. You just want someone to make a decision. So I was clearly not a surgeon. And I liked family practice, but, it was terrifying. How are you supposed to see and evaluate patients so quickly with all manner of different problems? You see 100 people with a cold and one of them has leukemia. And if you miss it in that 5 minutes, you've failed. That was way too much pressure. I greatly admire family doctors. I did not want to do that. And so that's sort of, I just eliminated a bunch of things. I ended up with thinking about pediatrics, which is quite similar to internal medicine. You have to deal with a lot of parents when you think about pediatrics. So I wasn't sure about that. And so, internal medicine allowed me to delay my hard and fast decision making. And honestly, it comes at you really fast. Medical school, you have to kind of know by third year. And that's not a lot of time to experience things. So I liked the idea about delaying this complex problem-solving specialization issues by doing a couple years of internal medicine. And then I was able to explore those different subspecialties. Again, it was about things I've already mentioned, like learning and keeping up with different treatments that come fast and furious, not getting bored, interacting in a very meaningful way with patients, and this group-based problem solving with lots of different options that you have to figure out who this person is in front of you, what their cancer is like, what all their other problems are, and try to come up with something that is meaningful for them. So that's, I lost track of your question now. Maybe that's part of the problem with being an oncologist.
No, that's great.
But I think, yeah, it is one of the things I liked was balancing all the different parts of a person into making their decision about their specific treatment. And one thing about oncology, which can be very difficult and can create a lot of pressure, but I also think is really helpful for sustaining interest, is that what you're dealing with is an incredibly important time in someone's life. And it is a privilege to be able to help somebody, even if all you can do is help them see that this is a difficult situation, that their life is limited, and that they have to really prioritize and think about the time and energy that they have left in the world. Those are really important discussions. And I felt that they were a meaningful way to spend my career. I'm here for 30 years. We put a huge amount of time and effort into getting here and school and training, and then you're here in the office doing things. I want it to have meaning. And with oncology, I felt like it has profound meaning and effect on patients' lives. And it's also changing really fast. The amount of treatments that we have now are significantly better than they were 20 years ago. The next 20, 25 years is going to be an amazing explosion of all sorts of different treatments and opportunities for patients. It's a really exciting time to be an oncologist. I didn't find that as much with the other subspecialties. So for me, it was pretty easy.
Right.
One thing I found was, a lot of people found it really sad, and it can be incredibly sad. But I also felt like it was an opportunity to really help people. And so, of course, it can be sad, but a heart attack is sad too. It's just a different way of becoming involved in people's lives and helping, and so that made it more meaningful to me. I did do a couple of different rotations. I knew I wanted to do oncology. I did think about other subspecialties as well, but I guess I thought about the bread and butter of what I wanted to see every day. Because I think it's hard when you're training, everything is so new and exciting and you're focused on learning that specialty. But, once you've been an oncologist or cardiologist or whatever for 5 years, you know all of the medicine. I mean, you're going to learn a few new things, but you know it all. So what is going to keep you interested day after day after day when you're seeing the kind of bread and butter stuff? And that's a really helpful thing, I think, to think about. It's hard to imagine what it's like after you know everything and then you're out there in practice, because it's easy to get attracted to the new learning and all of the excitement around a particular subspecialty. But if you think forward, okay, what's this going to be like in 10 years when I'm seeing my 9,000th diabetic or yet another person with COPD or something like that. And if that speaks to you, that's wonderful, because we need all of those things. For me, I needed to have something that I knew was going to change more rapidly over time.
Mm-hmm. And so you also mentioned that there's a lot of teamwork involved in your specialty, and that's also something that you enjoy?
Definitely. I like the interaction with other people. That can create conflict, and that's okay. There's room for that in anything you're practicing. So I do like the teamwork aspect of it. Not just, of course, other oncologists, but I work closely with a nurse practitioner. There's RNs and LPNs in the clinic all the time. Pharmacists are integral. Speech pathologists, nutritionists. I mean, it's a big team of people all looking after someone. And I like that. I like that aspect of it.
Is there anything that you dislike about what you do?
Well, I think at some point, politics and administration is frustrating for everybody. And I think that happens no matter where you are. So I work in a big hospital. I don't have much control over my computer or, what kind of schedule I have to a certain extent or who's working around me. On the other hand, taking a year of maternity leave was no problem. There's all sorts of people to cover for me. So, there's always pros and cons with where you work. I think most of us find politics and administration are the things that are frustrating or difficult, and that spans across all specialties.
Mm-hmm. And you also talked about how you enjoy the fact that it's sort of medical oncology, it changes very rapidly, and there's always new things happening. So in your view, do you find that there are going to be a lot of opportunities in the future for new physicians to come in and get involved?
Absolutely. I think oncology is one of the things that's changing the fastest that I can see. I guess other specialties may feel that way too, but our understanding of tumor biology and our ability to use integrative new technologies like genome sequencing, for example, technology is evolving and changing so quickly, and there's still so much we don't know about cancer that I think there's a tremendous amount of opportunity in oncology, which is wonderful. There's, unfortunately, the rates of cancer are going up. We have all sorts of new different treatments, so people are living longer. We still don't understand all the ways treatments work or affect people, so I cannot see any limit to the number of jobs going forward. I don't think that we're going to find some magic bullet and cure people in the way that they imagined in the 80s. I don't think that's actually fair to put that onus on oncology to cure something when we haven't been able to cure most things. So I do think that our opportunity in the next 10 to 20 years is to make cancer a chronic illness, like the way many illnesses are. And that's going to need people to look after them and change medications around. And that's a lot of opportunity. Yeah.
Fantastic. So do you have any comments about the work-life balance in medical oncology? I know that you have your family, and I'm sure you have hobbies and other things you like to do outside of medicine. So what does that kind of balance look like?
Well, I think burnout and work-life balance is an issue that cuts across all specialties. There's a lot of changes in medicine and medical practice and how the public perceives doctors and what they're expected to do. I think previous generations where being a doctor was your whole entire life and meaning and, provided the entire central meaning to your existence. I don't think that there are many doctors like that anymore. I think for whatever reason, it's not that same kind of drive to have medicine be the be-all, end-all of your existence. So we all fight pretty hard to have some work-life balance. Nobody comes in at 6 o'clock and says, "Hey, you've worked too hard today. You should go home now." You have to learn how to control the things that you're doing. You have to say no to some things. You have to set your own boundaries and limits, and they will be different than some of your colleagues, and that can be frustrating too. The one thing about medical oncology is that you're constantly reminded of the fragile nature of life and how precious our time here is. And I think that if that doesn't help you with your work-life balance, maybe nothing does. The number of people who we see who are waiting for their retirement or just waiting for something and then that doesn't come to be is right in our face all the time. And I think that helps us remember how important other things are in life. So yes, I have a family I care about a lot. I have a dog. I have, I love to kayak and be outside. I ski and, that's partly being in Vancouver. I love to read and travel. Well, can't travel anymore, but, all sorts of things. So I feel like I do as much as I can outside of medicine as well. But I also pick and choose what I do within medicine to try very hard to do the things that I find personally rewarding and work with people who are like-minded in terms of our research goals.
Mm-hmm. And I'm curious as well regarding the COVID pandemic, if it's impacted the work that you're able to do at all, and if you think that it's going to have any lasting impacts on your field in the future.
It has affected our work life, our work in general, in the sense that, especially early last year, but continuing on, we now talk to a lot of people by phone and try to administer some care by phone, which I don't actually like. And it's very difficult to get a sense of how someone is on the phone. It's an important aspect of medicine. We do a lot of outpatient care by the phone, but it definitely drives home how we do have to see people in person. Unfortunately, a lot of people aren't able to see their family doctors, so by the time I see them, they're sicker than usual. They don't like to come in to see us. So again, it makes the severity of their illness a little bit more significant by the time they get medical help. So I think that's been quite hard. And of course, people's isolation, very difficult. If you have an incurable cancer and your lifespan is limited and then you have to be by yourself in your house for your last year of life, that's terrible. That has a major impact on people. So I think we end up talking to some very lonely people, which takes up time. It's time consuming and difficult to provide the level of support that everybody needs. I don't know how it's going to affect things going forward. I think probably for the most part, we'll go back to seeing people in person as much as possible. What's really interesting is how the long-term effects of the virus itself will play out. Will this be a virus that leads to cancers, for example? All sorts of cancers are virally mediated. We're studying those. We're studying those with cancer genomics, which is really interesting. Who knows what the long-term effects of COVID will be from that perspective. So maybe we'll be talking about COVID-induced cancers in 20 years. I don't know.
Well, I think that's a great segue into speaking a little bit about your role as a researcher and the work that you've done at the Personalized OncoGenomics Center. Can you tell us a little bit about your role there and what that center is all about?
Yeah, so the Personalized OncoGenomics project, we call it POG. And then we use it like a verb, like we POG people. And when we have Pogapalooza, which is a big party every year to celebrate. So we call it, so POG is what we refer to it as. So it started, like 12 years ago with a patient of mine who had a cancer that was a little bit hard there was no real standard treatments for it. So I do what we usually do, which is I just was going to give him some standard chemotherapy, and he was very unhappy with that. He was a physician himself and a researcher, and he said, well, how come you can't just sequence my cancer and tell me what treatments I should have? And I laughed. Ha ha ha. I said, that's not how cancer works. And he said, well, but it should. And so we started talking to Marco Mara and Steve Jones, and Marco and Steve are the co-directors of the Genome Sciences Center. And that is a huge research organization that is one of the pillars of research under the BC Cancer umbrella. And it's a big organization with 13 labs underneath it, over 300 people and grad students and so on. So a big, big center. And we started talking about how could we use genomic technology to try to better identify treatments for individual people. And it was just good timing in some ways because there was a technological advantage at that point innovation, I guess, that suddenly allowed the sequencing to be completed much more quickly. And so we started down this project and we sequenced this patient, and I used that information to pick some treatments, and that sort of led eventually to the start of POG, which we launched in 2012. And it really started as a feasibility study. Could we biopsy patients and sequence their cancers, and would clinicians be interested in the information that came out, and would we be able to use it to better understand that individual person's biology and try to find drugs that matched up in some way to what was driving their cancers. And over time, this idea really took hold, and there was a lot of interest from clinicians and patients and family members. So it's been something that we've been now working on and expanding collaborations across the country and internationally as more people are able to actually sequence the entire DNA of a person and their cancer and the RNA, which is incredibly important. So we've learned to work together as a multidisciplinary team. Again, there's that theme where I really enjoy working as a group. And so I don't want some report or readout of these are all the DNA abnormalities of a patient. I actually want to sit with the genome scientist and talk through it and try to understand it using their expertise, not just assuming that I know things about genomics because I remember how to stick a fly onto a waxy stick. I need their expertise, and they need to learn. These scientists need to learn the importance of the kind of information that they're generating, and how we as clinicians treat that information, and how we make decisions around patient care. So it's really brought the scientists directly into the clinic, which has been a huge learning experience for them and for clinicians. So the ability to pull together a group of people to concentrate on one person's cancer at a time, it's really unique, highly rewarding experience. I think we've all really grown from that. And using cancer biology to try to direct patient care is an increasingly common thing for oncologists. So we already were used to a few different targets that we were able to measure, and that's part of standard of care. We already use cancer biology and some standardized tests to pick treatments. So what POG is about is trying to find targets for all the other people where that's not a standard yet. And when we find it and we prove it over and over again, then it becomes part of the standard. And so it's always on the edge of discovery and experimenting, I guess, hypothesis generation, which keeps us busy and keeps us on our toes, and it's very edgy, I guess, which is part of the intrigue.
That's fascinating. So it seems like the goal is really to deliver a very personalized type of treatment plan for the patient, rather than just like a general broad spectrum type of treatment.
Yeah, that's exactly right. If we can understand what's driving an individual person's cancer, maybe we can turn that switch off. And sometimes we can find a driver, but there just really are not drugs for that yet. P53 is a great example. P53 is a loss of a tumor suppressor gene. Well, how do you reinstate the loss of a tumor suppressor gene? We don't know how to do that yet. But if you find some other thing, KRAS is turned on, or that's a well-known one. You don't need POG for that. But we've found fusions that are novel fusions that we, have some hypotheses about what might be happening downstream. And then we target those things, and if it works in a couple of patients, well, suddenly that's something that internationally is being talked about. And POG has been the start of some of those really exciting, interesting innovations that gain a lot of momentum once we're able to publish them. And other people doing small projects around the world can see our results and leverage their own research. So POG has been a catalyst for a lot of different projects, and in fact is the catalyst for a big pan-Canadian data sharing project that the Terry Fox Research Institute and Foundation have been working with the federal government to launch this project called the Marathon of Hope Cancer Center Network. So Marathon of Hope Cancer Center Network is about creating a national database of 15,000 fully annotated cancer genomes. So if patients' cancers that have DNA and RNA sequencing and all of the clinical information that goes around that will be uploaded and shared across Canada, which then we can leverage for all sorts of extremely exciting projects and hopefully use that information to then develop new trials and understand tumor biology in a variety of different types of people and populations. Canada is so wonderfully diverse that being able to do research in that environment is very exciting.
That sounds amazing.
So yeah, POG has got a lot of it has the ability to enable people to do all sorts of different kind of research.
Mm-hmm. Is there maybe like a website or somewhere where students can go to check this out and see if they're interested in POG or the research that you're doing?
Yes. I think if you Googled personalized oncogenomics, you'll end up at the Genome Sciences Center website.
Okay.
Actually, there's quite a lot of information there. There's a bunch of videos explaining different aspects of POG. And our team just put through a successful grant to actually create a POG video that speaks more directly to the learning objectives of POG and so on. So yeah, if you searched that, personalized oncogenomics, BCGSC.
Perfect. Wow. Well, I guess I just wanted to ask you, is there anything else that you wanted to tell medical students, residents, or prospective students, anybody who might be interested in medical oncology? If you have any advice for them or anything else you want to tell them?
That's a very open question, Igor. I mean, I think that there's a huge amount of pressure in medical school to pick the thing that you're going to devote your whole life to. And I think it's okay to leave yourself open to change and experience and have an idea of what interests you, but not be scared that you have to pick the right thing right now, because you can change and evolve your career. It just takes energy and motivation to do that. Oncology is very, very interesting and exciting. And it is about helping people, but a lot of it is just about the energy and motivation to keep coming to work every day. And that speaks to the burnout question you asked. How do you maintain your interest 20, 30 years later? It's that you find your job meaningful, engaging, you like the people that you're working with, and you are making a difference in patients' lives, but you're doing that in a way that engages your brain. And I think that's why we're all in medicine. It's that kind of problem solving. Mm-hmm. So if that's the kind of person you are, then maybe medical oncology is for you.
And I think maybe having a dog might help mitigate some of that burnout too. You've got Toby in your background there.
Yeah. Nobody is ever as happy to see me as the dog. That's no, I think surrounding yourself with family and friends, those are critical. You've got to be reminded of the outside world and, how important life is. And, seize the day. It's true. You do have to seize the day. If anything, cancer tells you how precious life is. COVID can change your life in a minute. And so don't put off those things that you want to do. A group of us learned to snowboard when we were all post-call from CTU. It was crazy and we got injured and whatever, but this is the time, and you should make use of it.
Fantastic. Well, thank you so much, Dr. Laskin. Really appreciate you coming on the show and all your great insights. Thank you so much for being here with us today.
My pleasure.
And thank you all for listening. For more episodes of Metamorphosis, look for us on Spotify, Apple Podcasts, or wherever you get your podcasts. On behalf of the entire Metamorphosis team, we hope you're staying happy, healthy, and safe. See you next time.
This has been a presentation of the UBC Medicine Learning Network.